neuroscience meeting, and it's an honor for me to participate to this. Thank you also for asking me to speak about the arterial speed labeling. This is probably one of the most useful advanced MR technique in the clinical practice. And in this presentation, I will show some clinical application for evaluating the pediatric neurologic emergencies. I decided to divide this presentation into two main parts. During the first part, I will show you some tricks related to the perfusion techniques, in particular focusing on the technical parameters that should be correctly evaluated and set on a MR scanner for optimizing the imaging in pediatric studies. And then I will show you some cases in neurologic emergencies. The brain perfusion in children has been evaluated using many techniques. This technique can be divided into two main groups: those requiring the injection of exogenous tracer and those using an endogenous tracer. And you can see that the arterial speed labeling belongs to this second group. The gold standard for the evaluation of brain perfusion is still considered, I'm speaking about the MR perfusion techniques, the dynamic susceptibility contrast, which requires the use of a bolus of gadolinium. And in these techniques, we can estimate the parameters of brain perfusion during the passage of the bolus of gadolinium. In order to have an accurate estimation of brain perfusion, it's important to use an high flow bolus of gadolinium. To obtain this, it's important to use an injector, iron needle gauge, and altogether, this may represent limitation, in particular when we perform these sequences in very young children. On the other hand, the arterial speed labeling shows several technical advantages, practical advantages. In particular, it does not require the injection of gadolinium. It uses endogenous tracer, which is represented by the water molecules in arterial vessels. Of course, it does not require the ionizing radiation because it is an MR technique. And for this reason, it can be repeated many times, also during the same MR studies. And it also provides an absolute quantification of cerebral blood flow. When we acquire arterial speed labeling, it's important to consider two planes. The readout plane is also called the acquisition plane, which is the region of the brain where we are evaluating the brain perfusion. Another important plane is the labeling plane at the level of neck. This is the region where we apply radiofrequency pulses to tag the water molecules in arterial vessels. To obtain perfusion-weighted image, we first applied radiofrequency pulses at the level of neck in order to tag the water molecules in these major vessels. Then after a time, which is required to this molecule to reach the brain tissue, we acquire the image of the brain, and this is called the tag image. The same image of the brain is then acquired without applying radiofrequency pulse, and it is called the control image. The subtraction of the control image and the tag image provide a perfusion-weighted image. It is important to say now that one of the most important issues related to this technique is the very low signal-to-noise ratio. So in order to improve the signal in these perfusion maps, we need to repeat this process several times. So it is in a dynamic perfusion studies, and we need to acquire several times the couple image, tag, and controls. Another important consideration is related to the importance of post-labeling delay. As I said, this is the time required the water molecules, the tagged water molecules to reach the brain tissues. And it's important to know that these parameters should be changed on the MR scanner in order to improve the quality and the accuracy of perfusion evaluation. You can see in this table the values of this parameter suggested in the white paper published in 2015. And you can see that, for example, if you decide to study neonates, you have to use a longer post-label delay, in particular if you are studying the neonates during the first days after birth. On the other hand, the children, which are characterized by faster blood flow, need a shorter post-label delay, 1.5 seconds. And if you use a too short post-label delay, you can see on the left side of this image the results on perfusion-weighted image on ASL. You can see signal only within the arteries. On the other hand, if you use a longer post-label delay, the labeling effect on water molecules decay, so the residual signal is very low. So it's important to use the more appropriate parameter according to the age of subject. It's also important to know that there are different techniques, different arterial speed labeling techniques, according to the different ways we applied radiofrequency pulses. For example, when there is the pulsed arterial speed labeling, which requires the discontinuous radiofrequency pulses in a very large labeling plane at the level of neck. The continuous arterial speed labeling, which is probably the first technique which has been developed more than 20 years ago, which uses a continuous radiofrequency pulse in a very thin labeling plane. And the pseudo-continuous arterial speed labeling, which is the most used currently, is most used in clinical practice, which use a short range of radiofrequency pulses mimicking the effect of continuous arterial speed labeling. And if you want to know which is the best technique that you should use in your examination, you probably decide to use the pseudo-continuous arterial speed labeling because it's been demonstrated it provides a significant higher quality of MR images, and the ability to estimate the CBF is very good if you use this technique. Of course, the use of a higher magnetic field strength scanner are another important tricks that should be considered when you have to acquire perfusion imaging with arterial speed labeling. As I said before, the main issue is the very low signal to noise ratio. So the use of a greater magnetic field strength helps in obtaining a higher signal. So moreover, a 3 Tesla scanner, for example, we may have a longer T1 values of blood. This is a technical parameter used for the quantification of CBS in ASL approach. When you have a longer T1 values of blood, you have also a stronger ASL labeling effect, and the stronger labeling effect means more ASL perfusion signal. So if you can choose a 3 Tesla scanner, you should go for it. Now, let's try to understand why it's important to see a brain perfusion in neurological emergency in children. And I think there are at least 3 major mechanisms that can be impaired in neurological emergencies of children. We have lesion characterized by abnormal vascular supply, for example, the stroke or the hypoxic ischemic encephalopathy, abnormal vascular reactivity, migraine or infection and inflammation, such as encephalitis, or abnormal neuronal activity, for example, epilepsy or seizure activity, metabolic disease. And the brain perfusion studies may help in this condition to detect the lesion, may provide useful information for predict the clinical outcome in these patients, and it can be also used for monitoring the evolution of disease. So let's start from the youngest patients, neonates, and hypoxic ischemic encephalopathy. HIE is probably the major cause of death and disability during the first months of life in full-term neonates. And you know the pathogenesis of the brain damage is complex and is related to abnormal perfusion and abnormal delivery of oxygen to the brain tissue. These are images of a neonate with a severe form of hypoxic ischemic encephalopathy. You can see very low Apgar score, And these are images acquired during after 5 days after birth, term of cooling. So this is during the first week of life. You can see the typical pattern with the IT2 signal involving both the deep gray matter structures and the deep white matter. The restricted diffusion involving many structures of the brain. And here you can see the most frequent pattern on ASL images that you can find in neonates, asphyxiated neonates, the hyperperfusion of gray matter structures, involved in particular the deep gray matter and the cerebral cortex in the Rolandic region. ASL can be probably more useful when you have a milder form of hypoxic ischemic encephalopathy characterized by abnormalities, small abnormalities in the brain structures. This is a case of a full-term neonates. Also in this case, very low APGAR score. These are images acquired during the second week after birth. So we have a pseudo-normalization on ADC map and diffusion-weighted map, no longer visible the restricted diffusion, but you can see the abnormal signal on T2 and T1 weighted sequences, which are really important for detecting the brain lesion at this stage of disease at level of basal ganglia bilaterally. And also in this case, the 3D Picasso shows the hyperperfusion of the affected region of the brain. It is important to see at the brain perfusion in this group of neonates because the ASL may provide useful information about the prognosis of these neonates. In particular, if you can find hyperperfusion in a neonate after hypoxic ischemic event, the probability to have an adverse outcome is significantly higher. Another important application of ASL is the pediatric arterial ischemic stroke. The stroke in children is relatively rare, but it can lead significant morbidity and mortality in this group of patients. The risk factors, probably you know, are different in children compared with adults. Here you can see the most important etiologies of arterial ischemic stroke in children. The focal cerebral arteriopathy, particular post-infective, chickenpox infective, FCA, congenital vasculopathy, such as the moya-moya, and cardiac disease, and the predisposition to intravascular thrombosis. Here you can see the three major perfusion patterns that you can see in arterial ischemic stroke. The most frequent is the hypoperfusion of the ischemic core. You can see here the presence of restricted diffusion and the hypoperfusion that reflect the same lesion of the brain. It's important also to see at the periphery of the ischemic stroke on ASL maps, because sometimes you can see this spot of hyperperfusion within the vessels surrounding the ischemic core. These are called the arterial transit artifacts, and these are really important because the presence of these artifacts indicates the presence of a collateral perfusion and are associated to a better clinical outcome after the stroke. Moreover, it's also important to know that in particular in very young children and neonates, we may also observe the typical laxatory perfusion, which is characterized by the hyperperfusion of the ischemic core. This is a case of a perinatal ischemic stroke. You can see the restricted cytotoxic edema with restricted diffusion in the right side in the middle cerebral artery territory. You can see an increased representation of blood flow at MR angiography, and you can see that the ischemic core is characterized by the hyperperfusion. So it is a pattern that can be seen in particular in acute stage of perinatal stroke. ASL can be also useful for evaluating the ischemic penumbra. The ischemic penumbra can be evaluated using different approaches, using MR sequences. Probably the most used pattern is the evaluation of the mismatch between the DWI, which shows the cytotoxic edema, and the SWI, you can see here, which reflects the region of increased deoxygenation of the brain tissue with an increased representation of veins on this sequence. But at the same time, you can also evaluate the perfusion abnormalities and the region with abnormal transit time on ASL, which usually shows an area of hyperperfusion. And here you can see the arterial transit artifacts at the periphery of the ischemic lesion. And evaluating the mismatch, probably you can suggest possible intravascular treatment, even if it is not considered the gold standard in the pediatric population with arterial ischemic stroke. If you want to know which is the accuracy of ASL for detecting lesion in children with acute neurologic disorder, I suggest to read this paper, which was published a few months ago on neuroradiology. The authors basically compare a large group of subjects with acute neurologic disorders, both adults and children, and they evaluate the importance to evaluate the brain perfusion with ASL. And the sensitivity for detecting the brain lesion is really high, is more than 80%. And I think another important result of this study is the prognostic information that can be provided with the ASL perfusion map. In particular, if you can see lesion on ASL map, the probability for patient to have a longer hospital stay or future neurologic event is significantly higher. In patients with congenital vasculopathy, a possible treatment and therapeutic solution could be the surgical revascularization. And in some cases, the neurosurgeon asks for the evaluation of cerebrovascular reserve. The gold standard for the evaluation of cerebrovascular reserve is still considered the nuclear medicine technique, SPECT perfusion before and evaluated before and after the injection of the acetazolamide. But it's also important to know that if you want to go for a less invasive approach, probably you can use also the ASL acquired before and after the injection of acetazolamide in order to estimate the cerebrovascular reserve. Of course, we should be aware that there are many stroke mimics, which represent more than 20% of cases of children with acute neurologic symptoms. And I will show you some cases. This is a case of a girl, 14 years old, presenting at an emergency room with acute confusional states, disturbance of speech, and left visual loss. Here you can see normal structural MR images, no lesion on, no restriction diffusion on DWI sequences, no lesion on FLAIR, normal MR angiography. But if you look at the brain perfusion acquired at clinical onset, you can see the hyperperfusion of the cerebral cortex on the left side. The day after, the patient presented headache, so we perform again MR scan, and this time we found totally reversed pattern on brain perfusion. You can see the hyperperfusion of the left hemisphere. And after 5 days with headache resolution, we found the normalization of this abnormal pattern. This is the typical evolution of the migraine. Typical evolution of brain perfusion changes related to the migraine. It's important to know that in some cases, patients with migraine and aura did not show any abnormalities on conventional sequences. The presence of aura, in particular when the patient shows stroke-like event, is more frequently associated to the hyperperfusion, while the onset of headache is more frequently associated with the hyperperfusion. It's also important to know that the perfusion changes observed in patients with migraine in many cases did not match the boundaries of the major cerebrovascular territories. It's also important to know that that the migraine without aura attacks could be also associated with normal perfusion patterns. This is another case, a guy, 14 years old, history of cardiomegaly, presenting with acute visual loss and headache. This time you can see a lesion with a cytotoxic edema in the left occipital pole, which is also characterized by the hyperperfusion on ASL map. Looking at MR angiography, you can see an increased flow in the distal branches of the left posterior and middle cerebral arteries. And if you look at this WI, you can see a lower representation of veins in the affected region, indicating the presence of more oxygen in that region. So collecting all the data, probably the first MR image may suggest a possible acute ischemic stroke, but the other sequences did not are confident with this possible hypothesis. So it's important to use other advanced techniques, for example, the Mars spectroscopy, because the presence of a huge peak of lactate confirm the suggestion of a metabolic disorders, mitochondrial disorders. This is the typical pattern of a stroke-like event in Millers. This is a neonate with very similar lesion. Also, the neonate presenting with a right upper arm seizure after birth. You can see again the restricted diffusion in the left occipital pole. You can see the hyperperfusion on the left side. In this case, it's important to see the structural images revealing this malformation in the left hemisphere. It is a case of hemimegalencephaly, and these perfusion changes are related to the intense seizure activity. ASL is really useful for evaluating patients with epilepsy and seizure activity. In particular, it's important to know that perfusion changes occur in the early stages after the ictal state's onset. In particular, after the ictal activity, we usually observe hyperperfusion on ASL. When this hyperperfusion is no longer sufficient to supply the hyperactive cortical area, we may also observe the cytotoxic edema with restricted diffusion in DWI sequences. But it's important to observe that the perfusion changes precedes the cytotoxic edema. Of course, the ability of ASL detecting the perfusion changes related to the seizure activity are much more important in patients with epilepsy and negative structural MRI, which represents more than 20% of cases. For example, this girl, 11 years old, presented with prolonged seizures, no lesion on flare, no restricted diffusion on DWI, but you can see very well on PCASL the presence of hyperperfusion in the right frontal lobe. And it's important to know that these perfusion abnormalities are not longer visible if you perform a control study, follow-up study in the interictal state. So as a general rule, if you perform a perfusion study during the periictal stage after epilepsy and seizures, we usually observe the hyperperfusion on ASL. And it is a sort of functional hyperemia to compensate the intense activity of neurons in the affected area. On the other hand, if you perform ASL during the interictal phase, you may observe normal pattern of perfusion, or sometimes you can also observe hypoperfusion, in particular in cases when there is a lesion, epileptic lesion, such as a lead tumor or a focal cortical dysplasia. But there are some exceptions to this rule of thumb. For example, this case, 6-year-old boy, first generalized seizure, presenting with left frontal EEG abnormalities and the post-ictal right paralysis. These are images acquired 4 hours after seizure. You can see no lesion on flare, no restricted diffusion on DWI. SWI shows an increased representation of veins on the left side, indicating the deoxygenation of this region. No abnormalities on MR angiography, probably a lower representation of blood flow in the distal branches of the left arterial cerebral artery and the middle cerebral artery, but the brain perfusion revealed this global hypoperfusion of the left side, of the left hemisphere. After 42 days later, with the resolution of the right paralysis, the perfusion pattern was normal. And this is the typical pattern of the third paralysis following epilepsy. Now, in the last part of this presentation, I think it's also important to see something about the pediatric encephalitis. You know, this is one of the most challenging illness in medicine because there are a broad range of causative agents, both infection and autoimmune. The clinical findings are specific, and we have, in many cases, few specific diagnostic tests which helps to detecting the etiology of encephalitis. The neuroimaging, of course, is an important tool for studying these children. And it's important to know that in more than 60% of cases at clinical onset, MRI could be inconspicuous. And in many cases, MRI images are completely normal, despite the severe neurologic state of the patient. The most frequent MR findings at clinical onset are the asymmetric involvement of cerebral cortex, in particular in T2 and FLAIR, the hyperintensity of this structure, associated with the restricted diffusion, and cytotoxic edema with the swelling of the affected region of the brain. Arterial speed labeling and brain perfusion studies may provide useful information also in this group of patients. This is a case of a girl, 8 years old, with acute encephalopathy. These are images of MR images acquired at clinical onset. You can see no lesion on FLAIR and DWI, no core stress enhancement. But the perfusion study revealed this very peculiar pattern of perfusion abnormalities with a patchy hyperperfusion area associated with the other areas of hyperperfusion. And also in literature, this pattern has been described in many patients with autoimmune encephalopathy. It was a case of anti-NMDA receptor encephalitis. This is another case, a very young boy, 4 years old, with fever and altered of consciousness. Also in this case, no lesion on DWI, no abnormalities on FLAIR and T2-weighted sequences. This time, ASL revealed a global hypoperfusion. And this is an important pattern because the presence of hypoperfusion, of global hypoperfusion at clinical onset, in many cases is associated with a poor clinical outcome. These are images of the patient after a month with these wide abnormalities involving the white matter with a leukoencephalopathy and the presence of area of cytotoxic edema involving the posterior region of the brain. It's also important in patients with a pediatric encephalitis and a seizure to look at the brain perfusion in order to localize the ictal onset zone. This is a case of a boy presenting with fever, seizure, and altered consciousness. You can see this region of the restricted diffusion of the medial portion of the left frontal lobe, hyperintensity on T2 and FLAIR, and you can see that the ASL depicts very well the hyperperfusion, focal hyperperfusion of the region associated with the epilepsy. Also, the basal ganglia in patients with severe epilepsy during encephalitis, in many cases, are hyperperfused. What about the infectious encephalitis? You know, there are several patterns related to different distribution of brain lesion that may help in hypothesize the etiology of the viral encephalitis. This is a very interesting review published some years ago that depicts this concept. The brain perfusion in many cases is altered in patients with viral encephalitis, but it's important to say that there is no specific patterns of perfusion abnormalities that may help in detecting the effective etiology of the encephalitis. For example, in literature, you can find that the hyperperfusion, which is probably the most frequent pattern, is more frequent, for example, in herpes simplex virus-related encephalitis or in tick-borne encephalitis, while the hyperperfusion is more frequent in patients with HIV encephalitis. Last few slides to discuss something about the toxic and metabolic disorders, in particular, the posterior reversible encephalopathy is another acute neurologic event in children. It is characterized by a range of acute onset neurological signs, and the clinical features include seizures, altered mental status, headaches, cortical visual disturbances, and loss of consciousness. It's important to know that the standard MR scanner images are probably useful for revealing this condition, because there are distinct neuroimaging findings on these sequences. For example, the vasogenic edema involving mainly the posterior portion of cerebral hemispheres, like in this case, you can see the T2 flare hyperintensity involving the parasagittal cortex and white matter. Sometimes you can see also involvement the basal ganglia, the deep nuclei, thalami, and cerebellum. In some cases, also the spinal cord. But in very few cases, probably the most severe cases, you can see also hemorrhage and cytotoxic edema on DWI and SWI. The pathophysiology of the posterior reversible encephalopathy is not well understood. There are several theories. Basically, there are several triggers for this condition, in particular the severe hypertension or the use of drugs, immunogenic or vasoconstrictive drugs may induce perfusion changes in the brain. The problem is that different patterns of perfusion abnormalities has been described in this group of patients. For example, some cases has been described the hyperperfusion of the affected area, or in other cases, the hyperperfusion leads to vascular abnormalities and induce the vasogenic edema. Probably the mechanisms are not mutually exclusive, but I have this case studied this some years ago, which described that the problem perfusion abnormalities follow a specific pattern in PrEP. This is a case of a male with 11 years old with black fan diamond anemia, presenting at the acute stage with vomiting during headache 2 days after the stem cell transplantation. You can see no lesion at acute stage on FLAIR, no abnormalities on MR angiography. ASL revealed these focal areas of hypoperfusion in the posterior region of the brain. After 24 hours, the day after the clinical neurologic symptoms became worse, we perform another follow-up MR scan, and now we can see the typical findings of PRES in the parasagittal cortex, the posterior regions involved, some focal hypointensity on SWI indicating microbleeds, and the affected areas this time are hyperperfused. You can see here in the right frontal lobe and posteriorly in the parietal and occipital lobes, and it probably indicates that the hypoperfusion in PRES precedes the hyperperfusion, which is probably the most typical finding in the later acute stages of disease. Before to close this presentation, I would like to show you the results of this retrospective analysis we performed at Gaslini. We collected all patients with acute neurologic events presenting at the emergency room in the last 3 years. We found 136 children and started with both conventional MR sequences and pseudo-continuous arterial labeling. 67 children shows brain lesion detected on conventional MRI, while 69 children without brain lesion at conventional MRI. Of this second group, 37 presented abnormal ASL. So it described the importance of this sequence in the acute stage of neurologic disease, because in many cases, it may help in detecting perfusion abnormalities that precedes the lesions, which can be evaluated on structural sequences only in the later stages. So in conclusion, ASL may provide information that in some cases are not available with DWI and the vascular imaging alone. It's important to underline that it may help in identifying tissue at risk of infection, in particular, the evaluation of the mismatch DWI and ASL in the acute ischemic stroke. It's important to know that the ASL has a high negative predictive value for patient outcome, in particular, patient with neurologic deficit presenting normal ASL has a low risk for sequelae in the later stages. And finally, ASL may help in assisting the diagnosis of stroke mimics. Let me thank also people working in our neuroradiology unit at Gaslini. Probably you know some of them. I would like to thank also engineer, bioengineer, and biophysics helping us in the analysis these advanced techniques. And I think this is an important step for introducing these advanced sequences in the clinical practice. And I would like to thank you all for your attention and again for your kind invitation.
It was all very worth it. Amazing presentation, Domenico, and very, very clear. So it shows that you know very, very well what you're talking about. And I don't know, I will open, I have several questions, but I will open it to the floor first. And if my questions are not answered, then I'm very much keen to ask the questions actually. Let me see if I can go to the participants and make them allowed to talk. Sophie, you want to try to ask your question?
Great. Yes, thanks. Can you hear me? Have I unmuted?
Yeah. We can hear you well now. Yeah.
Super. Domenico, thank you very much. My name is Sophie Radker. I'm a consultant in the epilepsy team. And I was really interested in you talking about ASL for ictal hyperperfusion. So in pediatrics, in pre-surgical evaluation for epilepsy surgery, we used to use ictal SPECT, and as a very helpful investigation for looking for a seizure onset. Now it's really fallen out of regular use because of problems with getting availability of the isotope. So I was really interested in the possibilities of how you could use ASL in the same way. Felice's thoughts as well on that, whether, you know, because with ictal SPECT, we understood how to use it. We knew how long a seizure needs to be. We knew the window that we needed to get down to image, etc. Could we use ASL in this way? That's my question.
Thank you very much for your question. The ictal images with ASL is really interesting. In literature, you may find also some studies describing the use of ASL for describing the perfusion changes in the early phase after the seizure. And you will find discrepancy in the results because some studies describe the hypoperfusion in the very early ictal stages, probably during the first few hours after the seizure, the most frequent perfusion pattern abnormality is the hypoperfusion of the affected region. After these 2 hours, probably you start to see the hyperperfusion, which is described in other studies, and it is more frequent during the first, probably second day after the intense seizure. In clinical practice, it's very hard also for NMR studies to obtain a very early images in the ictal states, in the post-ictal states, because the patient should be present in the hospital and the scanner should be available for the study early after the crisis. And it is not possible in many cases. In our experience, we studied I think more than 10 patients early after seizure, and we found within the first hour the hypoperfusion in the affected region, in the region of the ictal onset zone. So I think in any way, this sequence is really useful for obtaining useful information in the post-ictal state, and I think it may be a possible alternative, less invasive alternative to PET.
Domenico, just to be clear, because the hypo and hyper cannot be very clear sometimes for all the audience and for myself. So within the first hour that you said that you scanned, it was low perfusion or high perfusion?
Low perfusion.
Low perfusion within the first hour.
Early during the first hour, yeah. And then higher perfusion then later.
Later on. Okay. Anushka, do you want to go on and ask your question?
Hi, Domenico. Thanks for a really excellent presentation. My name's Anushka, and I work as part of the neurovascular service here at GOSH, including looking after patients with moya-moya. And one particularly challenging group of patients we have are those with asymptomatic moya-moya. And I wondered if you thought there was a role for ASL in informing decision-making around this patient group.
Yes, the moya-moya, such as other congenital vasculopathy, may benefit for ASL analysis. There is an important issue for the use of this perfusion technique, in particular if in this group of patients, and also if you want to evaluate, to quantify the perfusion characteristic of brain tissue in patients with vasculopathies, because the signal on ASL map depends on the arrival time, transit time. So if you want to quantify ASL and CBF in this group of patients, you probably need to use a peculiar technique, which is called velocity selective arterial speed labeling, which provide ASL map considering the different arrival time in the different regions of the brain. So it may help in the quantification. In our practice, we use this technique qualitatively, using a qualitative approach, because this approach provides useful information in delineating the extension of perfusion abnormalities, and in evaluating also the improvement of brain perfusion, for example, after treatment. We also use this technique for evaluating the cerebrovascular reserve. Of course, we need to inject the acetazolamide during the MR scan and to acquire the ASL before and after. So we, using this approach, we are able to evaluate the ability of PL vessel to respond to a vasodilatory stimulus. So I think it can be useful also in this case for evaluating this group of patients.
Thank you so much. That's really helpful. Thank you.
Welcome.
Domenico, there is a couple of questions from a colleague, Kayar, from Pediatric Neurologist, a colleague. One is he's asking if this has been done at all for spinal cord perfusion abnormalities, if this can be done for spinal cord.
I have no experience about the spinal cord perfusion abnormal studies. And I think the arterial speed labeling may have some technical issue for the studying of distal portion of the body, because the labeling plane in the optimized sequences is localized in the lower portion of the readout plane. So to invert the orientation of this labeling is not easy. Probably it should be optimized, this sequence for research first, but I have no experience about that.
And what about if she's asking also if this has been studied in psychosis or functional neurological disorder?
Yes, of course. The ASL is also used, for example, for studying, for example, in adult patients for dementia. There is a close relationship between the perfusion abnormalities and the regions, for example, metabolic activities of the cerebral cortex. So the region with the abnormal metabolic activity of the cerebral cortex in many cases shows lower values of CBF. So considering this ability of ASL to detect these abnormalities, it may also use for studying this type of lesions.
One of my other colleagues, Dr. Prabhakar, who has also a headache interest, he's asking about the migraine findings. If you can elaborate, why do you think that this was initial hypoperfusion and then hyperperfusion? I'm not sure if you can elaborate or.
Yes, the typical evolution in migraine is probably related to a mechanism determining the clinical aura, the symptoms of aura. The vasoconstriction in some cases precedes or corresponds to the onset of neurologic symptoms of aura, and we look and we can see this the effect of vasoconstriction on ASL map with the initial hypoperfusion. The headache is probably a rebound to this initial vasoconstriction with the vasodilation of the peripheral vessels in the peripheral arterial in the PR region of the brain, which is associated with headache and which can be seen on ASL with a severe hyperperfusion in the affected side of the brain.
And there is another question which I think we're also interested to hear is your last slide about the study in your hospital where you had this cohort of children with normal MRIs and approximately half of them had abnormal ASL. Prab is asking, have you followed up like long-term clinical outcome on these cohorts of children to see actually if the ones with normal and abnormal ASL had different clinical outcome eventually after long term?
Yes, of course. We found the clinical outcome depends on the etiology of the neurologic events. So it is not directly related to the ASL finding. We collected the cases in the last 3 years. We are using a PCAVL since 2016. So we probably need to investigate a longer time in order to have a more structured study. This is a preliminary evaluation to understand if it is useful to introduce a protocol for studying children in the acute state, using also the ASL in the imaging protocol. And I think that the results of this study indicate that in some cases we are able to see some perfusion abnormalities which are not visible on DWI and MR angiography. I think that the findings that we found in encephalitis are also really interesting in this field because if you, many patients with encephalitis at clinical onset shows very few abnormalities or normal findings in MR scan. Despite the patient, it shows a severe neurologic impairment. So it means that there is a limit of imaging in that field in the early stages of disease. Of course, if you perform follow-up, later images probably shows other abnormalities, but in the acute stages, probably the brain perfusion is much more informative. So for this reason, it should be used for studying this group of patients.
My colleague Suresh is asking why low perfusion. I suspect, Suresh, you're asking about the epilepsy in the first hour. Is that what the first 1 to 2 hours? Is that what you're asking?
So the reason,
yeah. So he's asking why the epileptogenic area, the first couple of hours is low perfusion. Is it the same like with the PET?
I don't know if the same is the PET. I think it's not easy to study impact. So probably you have much more experience for the ictal PET than mine. But the reason are not clear understood. Probably there is a sort of vasoconstriction or related to the intense neuronal activities in the ictal offset region. Probably there is a sort of discrepancy between the metabolic activity and the ability of the arterial vessels to meet the metabolic demand in that region. So, or probably in epileptic patients, there is a sort, in that region, probably there is a sort of uncoupling of neurovascular mechanisms. So in the early stages, the vessels are not able to oversupply the region with intense activity. So, but these are all hypotheses. I don't think it's easy to demonstrate all these concepts.
Domenico, what happens in a case, because we had also had a previous colleague from India who had given an ASL presentation, but what happens in cases where you do the ASL in a cold phase when the patient is not having seizures? Do you still expect to see hypoperfusion there, or you don't expect to see hypoperfusion?
I think the hypoperfusion is much more evident, but in general, perfusion abnormalities in epileptic patients are evident, much more evident in patients with a clinical visible seizure. In other cases, probably the differences in brain perfusion, perfusion changes are very, very difficult to see. Now we are working also to a protocol to normalize the ASL maps in order to improve the conspicuity of very small perfusion changes in this group of patients with cold patients, and but we are working on that. And so probably the perfusion changes are not easily to see when the seizure are not clearly relevant.
The reason for NMDAR encephalitis showing this patchy hyperperfusion, do you have any theories about that?
There are some.
And is it specific also to that, or you have seen it also in other types of encephalitis? Sorry, just to answer both questions at the same time.
Yes, it can be seen also in other kinds of encephalitis. It is more frequent in the autoimmune encephalitis, so it is not specific only on the anti-NMDA receptor encephalitis. The reasons of this patchy hyperperfusion, hypoperfusion, is has been hypothesized, for example, an abnormal distribution of receptor. For example, the hyperperfusion, which is the finding indicating the affected region in encephalitis, probably is a region of the brain where the concentration of receptors is higher. So the inflammation in that region seems to be more important, and the ASL reflects this different distribution. But also in this case, these are hypotheses related to this different distribution of receptors that reflect the perfusion changes in the acute stages.
Yeah. Then Suresh makes a comment, which I'm not sure if you are going to be able to answer, but he says, if inspect, you expect, you are expected to inject very quickly, and actually the theory is that you have hyperperfusion of that abnormal ectogenic area. How come, that's still bizarre that in ASL you don't pick up this type of hyperperfusion, let's say? I don't know if you have a theory about this, or it's probably impossible to answer.
Yes, I have few experience with the SPECT perfusion. Yes, probably these two techniques reflect different mechanisms. Probably there are the SPECT probably using an exogenous tracer may provide a better evaluation and quantification of the brain perfusion. It does not mean that perfusion changes detected with ASL should not be considered in this field. So probably there is some studies comparing these two techniques in order to understand these discrepancies, but it's not clear, this difference.
Sorry, I have a colleague who just came. I had kind of several questions myself. I mean, me personally, I feel it's definitely a technique that we should be doing much more. We do it here as well, especially in the tumor, in the oncology field, but I think we should be doing it much more in all the fields that you just mentioned. And I can think of at least 3 clinical scenarios of where I thought, it might be helpful. One, of course, was children who have difficult epilepsy and either are either MRI negative or they have very funny types of events where and maybe funny areas of lesions. So I think we had recently a case where we couldn't even decide if the child was having seizures or not, but with a brainstem hamartoma, where there had been actually studies maybe with SPECT showing that there is actually involvement of that tissue in some sort of ectogenicity. So I think one clinical scenario is this, or MRI negative cases. Then press cases where we're not sure what's going on, if it's really press or not, but also in cases where we're not sure if what we're dealing with is ischemia or excitotoxic damage. For example, we're not sure if we have an infarct or we have something secondary to prolonged seizure. So we have had cases like these, real cases which troubled us, and I think ASL might have helped at least in clarifying some of this. So definitely it's a technique that we should use more. One of the things that our neuroradiologist says that we don't have any normative data. So is that what you're trying to create now? And are you going to publish also the cohort that you just mentioned before?
Yes, it's an important point, the normative data. Of course, the first issue related to collect normative data in children is to obtain the ethical concept for studying these patients. We collect all cases in our cohort studied with Picasso, a 3 Tesla scanner with normal MR, and for example, excluding headache and neurological symptoms, and including only small traumas or minor trauma. So of course, it could be considered a sort of bias in the selection, but at the moment, it is the normal data that we have in our institute. We have at least 200 of normal subjects with normal ASL and normal MR images. There is also a way to evaluate if the ASL is normal or not. For example, we can compare the left and right hemisphere in the single subject to exclude the presence of asymmetry and significant asymmetry between the two hemispheres, or we can compare the values detected in cerebral in different regions of the brain with normative data obtained with other perfusion techniques in order to establish if there are some significant difference. But it is used mainly for research. So in clinical practice, it is not easy to obtain this data.
And one last question from me, real life question. In cases of stroke where you have a discussion, I'm not sure how much you use thrombectomy in your hospital, and if you have done usually mechanical thrombectomy in children, but
very few cases.
Very few cases. I'm just wondering if you use the ASL on the hot acute phase to make the decision, or you just use the DWA flare mismatch to make the decision. Or how do you make a decision of thrombectomy or not?
These cases are not recent. So in that cases, we use SWI, DWI mismatch, but I think the same information can be obtained using also ASL. So in many cases, the areas of the cytotoxic edema and the delay transit time corresponds if you use SWI, Picasso. And so
Felice wants to say something.
Just one question about this point that is very interesting. So how you calculate the MTT using ASL? Because one of the problem we have is that you have CBF that of course corresponds to the core, at least in all the fuse study and the adult studies, they use the CBF as core, but of course the MTT in the contrast perfusion can be used, and there is a lot of experience in the adult side as penumbra. So how you use, because you mentioned the transit time, how you do that on
so in order to quantify the arterial transit time, you have to use a multi-delay arterial speed labeling. Basically, the path label delay could be single if you have a standard acquisition, but you may also acquire multiple delay and to evaluate the different velocity of arrival time according to the different delay times. So it's a different type of acquisition. which may help in the quantification in the arrival transit time. On the other hand, you can evaluate the TBF map obtained with a single post-labeling delay time using a qualitative approach to describe the region of the abnormal perfusion. So it is a qualitative analysis and it is not a quantitative analysis. But there are also some studies which, for example, use the covariance of ASL signal within a specific region of interest, which has been demonstrated to correlate with our arterial transit time. So you may use different approach, but of course, the pure quantitative analysis required a specific acquisition, multi-delay acquisition with ASL.
Okay, thanks.
Domenico, we kind of finished our time, but we're extremely grateful. First of all, I have to say, you know, I'm a big fan, and I think we should be doing this much more than what I hope also my neuroradiology colleagues feel the same, because I think there's a lot of potential for this. And it's definitely a non-invasive method on top of everything else. And it may replace other methods which may be more invasive or more radioactive. So thank you very much for doing this presentation. We're looking forward to it. I don't know if you have published already your series or if you're planning to publish, but please alert us and maybe we ask you to speak again if you have even more data.
Okay. Thank you very much for inviting me. It was a pleasure for me. Thank you again.
Thank you. Thank you very much again. Thank you. Okay. We're grateful.
See you.
Okay. See you next week.
See you next week. Bye. Bye.